Perfect. So welcome everybody to our recognition and management of sepsis in children. Today is going to be facilitated by myself, Alicia Hayes, as well as Tiffany Yam and Deborah Schoenfield. A little bit of an introduction. So Tiffany has been at SickKids for 13 years, and during this time she's worked as a RN on our general medicine pediatric floor. She's transitioned to various roles in that environment, including working as a clinical support nurse. Tiffany has also supported the University of Toronto as a clinical instructor, leading nursing clinical skills and development. And she also graduated from U of T with her master's in nursing in health system leadership and administration. And she's worked in various leadership roles here at the hospital. And she's currently working in the professional practice at SickKids as a clinical extern coordinator. And today she's representing professional practice as a clinical nurse specialist of the sepsis program. And Debbie is here as a full-time staff doctor in our emergency room here at SickKids, where she's worked for 11 years. She also holds a certificate in patient safety and quality improvement from the University of Toronto. And she has a special interest in the recognition and management of sepsis in the pediatric ER, and is the physician medical lead for the SickKids sepsis program. So we have a wealth of knowledge today. So just to let you know, the information that we're going to cover today is by no means everything about sepsis. We're going to start to touch on everything, but we don't want it to be relied on as a complete statement of subject matter. So today we're going to have lots of opportunities for questions. Feel free to ask them. You can also get in touch with us as well going forward if you have any other questions. Just so that we have the most out of today's session, because the session will also be recorded. If you can mute yourself when you're not speaking, just so we don't get a lot of feedback, but feel free to unmute at any point if you have any questions. Feel free to turn on your video. You can use the chat for questions or comments. We're going to be monitoring that. And yes, participation is encouraged. So if you have a question in time, feel free to ask it. Otherwise, we'll also save time at the end as well. So today we are going to talk about sepsis, and we're going to define what sepsis is as well as what septic shock is. We're going to understand the key signs and symptoms of sepsis, and we're going to look at recommended best practice for assessment and management of sepsis. We also are hoping to hear your experience with that. And again, if you have any questions, let us know. So to get started, I'm going to pass it off to Tiffany.
Thanks, Alicia. All right, so as Alicia shared, we're just going to start off by talking a little bit about the different terms that we might hear around sepsis and understanding what we're talking about when we're talking about sepsis and sepsis shock. Okay, next slide. So for many of you guys here, I think a lot of this information might be something that you guys are familiar with or have experience with in your practice. So we'll be curious to hear about things that you guys might have seen in practice as we talk through this together. So sepsis is potentially a life-threatening condition that results from a widespread and exaggerated immune response to an infection. And so when we're thinking about sepsis, this can be really any type of infection that the body tries to fight, from those invading pathogens. And so this is done through activating an inflammatory response. And this response sometimes evolves into being exaggerated and uncontrolled and potentially causing injury to the body's tissues and organs. So we really want to prevent that, and we'll talk about that pathway a bit. The infection can result from any type of infection in any part of the body, and a common misconception is often that sepsis is the same thing as bacteremia. So bacteremia can result in sepsis, but just to clarify, you can have sepsis in the absence of a bloodstream infection. Next slide. All right. So why do we really care about sepsis? We know that pediatric sepsis in Canada accounts for approximately 4,000 hospital admissions a year and 200 deaths per year in Canada. So as we kind of talk through some of the materials, we do want to think about all of those instances where we might have an opportunity to identify and really hone down on what those actions might be to mitigate some of those risks. Next slide. All right. So some of the factors leading to poor outcomes really focuses on delays or gaps that might result in recognizing sepsis, the communication that occurs within your teams. So whether that's handoff or transfers of the patients, delays in timely escalation for IV access, IV fluid resuscitation and antibiotics, which we'll talk a little bit more about, as well as any gaps in the monitoring and pathways for escalating care. So we know that any child can develop sepsis. We'll talk about some of those risk factors for individuals that might be at higher risk for getting it. So we really have to treat it and recognize it early on. And in order to do this, we have to think about using sometimes the words of sepsis. So if you are concerned about a patient that has it, calling it out, and we'll talk about some opportunities to do that. Next slide. Okay, so in terms of how we define sepsis, we tend to think of a spectrum of severity that ranges from early indicators of systemic inflammation to sepsis shock, all the way to multi-organ dysfunction. And so without proper treatment, we know this can potentially lead to death. So you really want to avoid that. At the beginning, SIRS, which is systemic inflammatory response syndrome, refers to a collection of signs that suggest the presence of systemic inflammation. So this is your body's initial response to an infection or a suspected infection. And it can present as tachycardia, tachypnea, and or abnormal leukocyte counts. And SIRS in infants, we know, can also sometimes present with different symptoms like hypothermia or bradycardia. We diagnose sepsis when we observe these signs of inflammation or SIRS as it evolves to sepsis when suspected or proven infection. And the point to add here is just that sometimes it's just a suspected infection. So we may never initially find an invading pathogen that we're concerned about. More than 1/4 of Canadian children with severe sepsis experience multi-organ failure. And then in children who actually do experience hepatic or central nervous system failure, that mortality rate reaches 50%. So we really kind of want to avoid that end pathway. Next slide. Right, so identifying risk factors. What are some of those symptoms that we might see? So the challenge with sepsis is that some of the symptoms and signs can be really nonspecific or attributed to other clinical diagnosis. So sepsis can notoriously be really difficult to identify, even if you're a very experienced clinician. I know in previous webinars, we've shared a little bit more about the history of our sepsis program here at SickKids. And sepsis initiatives really started initially with the death of patients that related to delay in identification of sepsis or management by clinician. And in all these cases, physicians and nurses were extremely competent and had knowledge and exposure of sepsis. So it's a really good reason why we know we have to maintain that vigilance and think of sepsis as a potential cause for symptoms. We've since in that program done a lot of work to help spread some of that knowledge as well. So identifying sepsis requires a thorough identification of clinical history. This helps you identify high-risk conditions, vital signs, and a physical examination is not needed. We know that some of those indicators are as listed here. So fever, cough, sore throat, vomiting, diarrhea, skin rash, joint pain, swelling, and malaise. And other high-risk conditions also include the age of your patient. So younger children, especially those below the age of 3 months, are at higher risk. Those with indwelling medical conditions such as central lines, enteral tubes, trachs, medical devices that may be related to their underlying condition, such as a complex chronic condition. recent surgery, incisions or wounds, or conditions where they may be taking medication that suppresses their immune system, as well as patients that are asplenic. Okay, so the key point here is really that any child can develop sepsis, but we really want to think about all of those factors that may come into combination together. All right, next slide. Okay, so we'll do a quick case scenario with everyone, and we'd love to get your thoughts here. You have caregivers that had brought their 8-year-old boy in to emerge because he had woken up that morning looking quite unwell. He presents with a high fever of 3 days, decreased oral intake, vomiting for 3 days, and has abdominal pain, an occasional cough. His weight is 25 kilos, and he's otherwise healthy and fully immunized. So his vital signs are here as listed, and he's been irritable to touch. His cap refill is less than 4 seconds. So let's say that you're working through this child and they're being assessed, through triage. So my question for the group here is, are you worried for sepsis, and why or why not? So you can kind of add your answers to the chat or come off mute.
So Tiffany, someone commented the temperature is worrisome, perhaps draw some labs.
Okay. Anyone else?
And also do an assessment. Have they been drinking despite the vomiting?
Perfect. Yeah. Yeah, and that's great. We really kind of want to think about doing an assessment and vital signs, or a full set of vital signs to start off. And yes, we definitely are concerned for potential sepsis, even if we're not entirely sure. Yeah, and so again, using those words of thinking of, if you are concerned of sepsis and why, related to maybe some of those things that you guys had listed. So fever, looking unwell is really a key factor here. Right, next slide. Okay. So abnormal sepsis vital signs, we're going to talk a little bit more about the changes in vital signs that are often the first clue for sepsis. Really, we know that children are not just small adults, and so vital signs ranges are specific for peds, depending on their developmental age and size, and it's very important to ensure that you guys have access to those resources that reference pediatric vital sign ranges. And we know here at Sick Kids, we have that often integrated into our chart, but some people also have references for pocket cards. So in community, if you guys have those references available, those all are always handy to have. So the most important factor here, before I get into those individual vital signs, are that we really want to think about vital sign trending as being really important. Any child becoming progressively more tachypnic or tachycardic must raise concern versus just one set of vital signs in isolation. Oh, perfect. Yeah, I have some comments here that people have some resources available for them. That's great. So in children with sepsis, tachycardia, fever, and tachypnea initially may be your first early signs. In some of those younger children and infants, you might see hypothermia and bradycardia additionally as present. And as sepsis leads to abnormalities in your cellular metabolism, you might see those heart rate increase. And that is a change that occurs because kids are trying to maintain that cardiac output. They may try to breathe faster to get more oxygen to their tissues to keep up with those metabolic demands. And so as that compensation begins to fail, only then do we see those later signs, which is hypotension, and then that widening pulse pressure. So we really want to ensure that we're activating that support and intervention before we get to those later stage. Okay. You can go to the next slide. All right. So we'll talk a little bit more about best practice recommendations for measuring vital signs. If you're looking for any of these resources too, just because I won't be reading every single point off the slide, just refer back to the recording or reach out to Alicia to get these slides. Okay, so we really want to make sure that we're using the right tools to be able to properly assess for vital signs in children. First, for temperature, we know that oral and rectal are the most reliable and recommended routes. So we do want to make sure we're selecting the correct way of measuring with the correct devices that's appropriate for that developmental age. So for rectal, we do want to ensure that we're lubricating the tip and inserting approximately 1.5 centimeters. The age ranges for each of these devices are up here on the slides. A good point to think about is that we have contraindications for some patients for rectal temperatures. So don't be using our rectal temperature for patients that have bleeding risk, trauma risk. Other examples are kids that might have low neutropenia, low platelets, or bradycardia that is related to vagal stimulation. Some of those contraindications for oral temperature might be some of the kids that either developmentally can't hold it in their mouth or has been recently sedated on oxygen or have recently drank hot or cold items right before taking it. For our heart rate and rest rate, we want to assess for a full minute. So we're looking for rate and rhythm. And so for heart rate, we're assessing those infants at the apex. For our older patient here at Sick Kids, we still do auscultate for a full minute, but some of you guys in community might be doing radial pulses. And then for rest effort, we really want to be taking a listen to the quality and rhythm of their rest. So we're looking for work of breathing. Is there grunting? What is the quality of their rest rate itself? And then lastly, for blood pressure, we really want to ensure that we have the proper cuff size for the patient limbs. So sizes that are too large or too small may result in inaccurate readings. And we do want to make sure that we're interpreting these automatic results with caution, because sometimes we know those blood pressure machines can really make patients upset or irritable, and that can cause an inaccurate, potentially higher blood pressure value. So we really, especially at Sick Kids, we've tried to focus a lot on making our patients comfortable with distraction or using the support with the caregivers to help distract them and to get a blood pressure while they're calm. That's not always feasible, but we try our best to do that. Okay. And I'll hand it over to Alicia.
Okay. So I'll go into sort of the second part of the talk here. Oh, sorry. You know what, Alicia? I literally just thought it was my part.
No, that's okay.
I did not realize. I'm so sorry.
No, that's okay. No problem. We'll jump in just before we get to there. We're just going to touch base for some physical exams, some things that we can do in terms of health assessment. And I just wanted to add in, I know Tiffany mentioned that we can refer back to these slides. This, like you said, the slide will be recorded. There's also other health assessment webinars on our resource hub that we can refer to as well. And I'll make sure that everyone has those, that website at the end as well. So just to add on to Tiffany's statement, so if sepsis isn't detected early, it can evolve into impaired tissue and organ dysfunction, and all things that we want to avoid. So a physical exam is really important to be able to detect those signs of the evolution of sepsis, and then we can put those findings together to get a greater picture of what's happening with the child. So, for example, impaired perfusion to the brain may present as a subtle change in mental status. And so this is one way that we can look at, is there impaired perfusion? So assessing the mental status of a child can definitely be challenging, especially in the context if they're uncomfortable, or are they in pain, are they just irritable because a healthcare provider is around and they're nervous. So we're looking at unexplained irritability. Are we looking at increased drowsiness, confusion, lethargy, or unresponsiveness? But thinking to that this can be challenging to assess in a child, how do you think that you would establish a baseline, or how would you encourage your staff to establish a baseline for the mental status of a child? Yes, so I can see that someone says ask a guardian. Perfect. So that's really important and a really key thing that we want to get across is that establishing the baseline is really important. And one way that we can do that is partnering with the family caregiver or with the family that's there to know what their normal is and listen to their cues. So if they're very concerned that this isn't how their child would normally act or it's not how they've reacted previously, that can be a really good indicator that something else is happening. And yeah, great, asking the patient. So can you get any information out of the patient and are they responding appropriately? In addition, when we're looking at tissue perfusion, we can also do assessments of the skin and pulses to see if we are getting proper perfusion. So in children, it's more common to see cool, clammy skin, delayed cap refill, and weaker pulses on the assessment. But we do also see warm, flush skin, flash cap refill, and then bounding pulses. Those all can be signs of poor perfusion. We just tend to see the top ones. So the molting, cold, clammy skin, delayed refill, those are the more common ones. But again, we can kind of see all of this with children. Another marker of impaired perfusion, especially impaired kidney perfusion, is looking at urine output. So decreased output can be a very common thing when this is happening. One way that we look at this for pediatrics is we look at it from a milliliters per kilogram per hour ratio. So one way that we do it is looking at just total number of wet diapers, but then if we actually want to know the value of it, we will weigh the diapers and we'll take the total volume and divide it by the weight of the child. Another thing that you can do is asking families, are they frequently changing the diaper? When they change it, does it feel as heavy as it is? Have they seen a decline in that? And so again, really engaging the family in these assessments. Okay, so we'll do a bit of another case scenario. So we're thinking of the same child before. The parents have brought their 8-year-old boy to the emergency department. He woke up looking unwell. He had that high fever for 3 days, decreased oral intake, vomiting with abdominal pain and an occasional cough. Otherwise, he's healthy and fully immunized. His vitals are still there. We talked a little bit before about further assessments that we can do, but is there anything else that you would be considering? Now that we've covered a little bit more information, is there anything else that you might ask? Okay, so yeah, Michelle noted that worried, looking for maybe a chest x-ray, any other diagnostics, or check urine output. Great. Yeah. So thinking about, what has his urine output been? I know we talked before that he has decreased oral intake. So how has that impacted? Talking to the family, we know that he's unwell, that he's a bit irritable. So is that his normal? Has that changed? Is it getting worse? And then looking for, now let's check his pulses, what the rest of the skin look like, so then we can put that together with our vital signs.
I think a key thing here too, I'll just throw in is that we have our initial set of vitals, but something we talked about earlier is doing that trending. So as you are working with your child, still continuing to get another set of vitals to see if there's change in it, because we really want to think about not just that one event that happens, but what might be happening in the next few hours after you see them too.
Perfect. So just a bit of a summary of some of the assessment points. Some key points to consider is that sepsis can occur in any child, but we want to pay close attention to those patients that have the high risk indicators, and we want to look for them as a part of a whole clinical history. Like Tiffany had said, we're paying attention to the abnormal vital signs, but then also looking at the trend, and then how it's evolving over time. With children, we know that hypotension is a late sign, so we don't want to rely on that entirely. If we want to look for those other changes, like changes in respiratory rate and heart rate as well, are really key important signs. And then assessing for impaired organ perfusion, and then also having that clear communication with your team. If you're concerned for sepsis, acknowledging that and using those words that you're concerned for sepsis, because there's no harm in saying you're concerned for sepsis. And if you're wrong, then that's okay. They've gotten treatment and further assessments, but we're just trying to avoid those times that we miss that. Okay, Debbie, off to you.
Okay, now I'm up. Now I'm up for real. Okay. So I'll sort of take over the last part of this talk right now, which really is going to revolve around what do you do now that you've accomplished the difficult task of recognizing sepsis, which in itself can be tricky. And a couple of things I just sort of want to emphasize here, that what you do in the first hour can potentially make all the difference in a child's life. So I really just want to emphasize that this sort of first hour between recognition and those initial steps that you take are really, really important. And there's lots of evidence to support that, which I won't bore everyone with today, but sort of take my word for it as someone who has seen this dozens and dozens of times in the emergency department. These sort of initial moments and minutes really are critical. So next slide, please. So we'll center this conversation also sort of around a case discussion. We'll switch over right now to a 3-year-old who presents to the emergency department with a 2-day history of fever, vomiting, decreased urine output. In ED, you find that he has a fever, he's tachycardic, he's tachypnic, and his cap refill is 3 seconds. His blood pressure and pulses are normal. He seems just tired and lethargic, according to his parents and your exam, but he's responsive to your voice. He wakes up and sort of follows your commands. So you as the nurse call the most responsible provider. So sort of I'll ask in this case, it's sort of a bit of a rhetorical question, sort of given the talk that we're in right now, but I do think it's important to just sort of go through the mental exercise of sort of why you might think so. So do you think this patient has sepsis or septic shock, or one more so than the other? What do you think? Do you feel confident you could say this patient is exhibiting signs of septic shock? Is it just sepsis? Any thoughts? Okay, great. If they're also hypotensive, I'd assume septic shock. Fantastic. Okay, we'll talk a little bit about that. So just as a sort of quick reminder, and Tiffany went over these definitions, but strictly speaking, so any patient who you suspect has an infection, so I would argue in this case, I think we suspect that Leo has an infection given the fever, vomiting, and exhibits signs of the systemic inflammatory response, which Tiffany went over as well. So things that are involved in the systemic inflammatory response, just as a reminder, include temperature abnormalities, white blood cell count abnormalities, heart rate abnormalities, and respiratory abnormalities. So Leo already sort of meets criteria for having the systemic inflammatory response because he's got fever, tachycardia, and tachypnea. So by definition, I think we can pretty confidently say that Leo is exhibiting signs of sepsis. So the question then becomes, does Leo have septic shock? And septic shock is defined, just as a reminder again, as sepsis with signs of cardiovascular dysfunction. And to make this really easy, it just means are his organs and his body getting the perfusion and oxygen delivery that they need? Okay, so if you think of it that way. Now, Tiffany sort of went over that really, really important point of altered mental status and why that's such an important thing to assess. And the reason is really that altered mental status is really a surrogate for brain perfusion. So if your brain is not being perfused properly with blood, you may have altered mental status, and that is a sign of cardiovascular dysfunction. So I would argue that, Leo is showing signs of sepsis, but he is also exhibiting signs that possibly he's entering a stage of septic shock, that, his brain is not being adequately perfused. Now, realistically, many of us has seen a child like this who ultimately doesn't end up having septic shock, as Alicia sort of just said. Maybe he's horribly febrile, and many of you may have children who become, have hallucinations when they're febrile, or really are not themselves when they're febrile, or maybe he's badly dehydrated from his vomiting. All those things are possible, but I would say it's important to sort of think of the worst case scenario here, which is that Leo is sort of entering a state of septic shock. So with that, I'll ask sort of, again, sort of how would you communicate this to your team? So you're the RN on this case, and you want to get your doc's attention. We're a small group here, and I think sort of the point of this is we'll show the video sort of elsewhere after this talk. But the point of this question was really to get you guys to hopefully use the S word, which is sepsis, when you call someone, and clearly say, rather than, you could go on sort of a whole spiel about, you have a kid, he has fever, he has vomiting, he has tachycardia, he has tachypnea, you don't really like the way that he looks, he's not really behaving normally. At the end of the day, it is incredibly effective to say the sentence, this child looks unwell, I'm concerned he has sepsis. We are encouraging that throughout our organization, and it's become sort of a regular word that we try and really sort of normalize. And as Alicia mentioned, some of the times, you'll give Tylenol and, the kid will come around and look better. But for all those times that they don't, you'll be glad that you used the term. So next slide, please. We'll get into a little bit about sort of treatment now. So what, ultimately the goal in sepsis treatment is to ensure that the organ dysfunction that can result from sepsis is minimized. So you first, as I just sort of mentioned, you want to establish a shared mental model with the healthcare team and really say what it is you are concerned about. We'll go through each of these, but you're going to apply oxygen and complete monitoring on the patient. You'll establish IV access, ideally 2 sites of IV access. We'll talk about this. You'll collect some investigations. You'll provide fluid resuscitation, of course, start antibiotic therapy. And then if you don't have higher level resources that you may need to take care of a sick child, you want to start exploring options for transfer and consultation with other places that can provide that care. And then in select cases, which we'll talk about, source control. So next slide. So this is just, I just wanted to sort of throw this in there for those of you that carry around any of the PALS pocket cards. It's incredibly helpful and gives a really nice sort of visual of what should happen within this first hour after you've identified signs of septic shock and what you should do. I think we'll go through the elements of this algorithm in the next few slides, but I do think this is a really, really concise and very clear algorithm that you can just have in your back pocket if you need it. The other amazing thing that is on this pocket card that I really think is invaluable as well, as we've alluded to many times, sort of picking up on tachycardia and tachypnea. And Michelle very astutely used the words earlier when she wrote, tease out if this is tachycardia for this patient. And I actually loved those words, tease out, because it really insinuates that it's not that easy. We talk about sort of, I love that. I'm going to sort of use that going forward. We talk about it like it's so easy, like, okay, well, decide if this patient is tachycardic, or notice tachycardia, or note tachycardia. It's not that easy because it differs in every single solitary age group, right? And unless you have a resource that you can go to, and that tells you, this is abnormal, you may run into trouble. And Tiffany mentioned we have an EMR. We're very blessed with an EMR that color codes everything. So it's very hard to miss tachycardia if you work at Sick Kids, because it's a red alert that sort of pops up, in your face next to a child's vital sign, especially if you work in the emergency room. But there's many places, the majority of community hospitals are still working on paper right now, right? So that's somebody writing down a manual heart rate and you having to sort of have the knowledge and cognitive bandwidth to sort of recognize that 160 is too high or too low for a certain age group. So it's really good to have a pocket card or something that's at your disposal, or an algorithm that's posted somewhere on your floors or in the emergency room to help with that. And someone just mentioned the value of early warning scores. And that is another fantastic, I give another talk on this and I sort of show the different resources available. And the pediatric early warning score is another great tool to use as well. But again, if you use paper documentation, and I remember sort of the days of doing my residency and just being in the ER and seeing a flow chart, with 10 different heart rates on them and just having no idea if something was too high or too low. So I would really, really, really encourage you to have what I call sort of a source of truth, or like a go-to for your, what is the appropriate range, so you can sort of quickly know. And, if you have the ability to post something like this on your ward or in your ER, I think that is a great, great idea too. But this is just sort of one way you can do it, by having sort of this pocket card in your back pocket. But next slide, please. So sepsis treatment goals, I went through sort of some of these in the table I just showed, but, because sepsis leads to leaky capillaries and sort of everything sort of leaking out sort of from your veins, and an inability to sort of maintain an adequate circulation, we often need to restore this intravascular volume through fluid resuscitation. We talked about how also, because of this sort of leakiness and inadequate perfusion, there's inadequate oxygen delivery to the various organ systems and tissues, and we'll talk about what that does. So you want to increase oxygen delivery to tissues. You want to treat and reverse that organ dysfunction that results from impaired perfusion to all those organ systems. And then, of course, you want to treat the underlying source of infection so you can stop this sort of dangerous cascade of inflammation. Next slide, please. So just a word about, monitoring. Of course, these patients have the ability to deteriorate very quickly. I'll tell you, as recent as this past spring, we had a case in our emergency department, a child who came in walking and talking and died by the end of their emergency department visit. So these kids are okay until they're not okay. And we'll talk a little bit about more why it's sort of more subtle in children maybe than it is in adults. So you want to apply full monitors because you want to make sure you sort of have your finger on the pulse and you can detect changes and, as Tiffany mentioned, trends in their vital signs. So you want to have them on continuous monitoring. That includes continuous ECG monitoring, so you can get a good idea of their heart rate, their oxygen saturations. We generally apply oxygen on all these kids, and it's not necessarily because they'll have low oxygen saturations, but as I mentioned, because of this impaired perfusion, tissues are not getting the oxygen that they need. So you really want to maximize the oxygen carrying capacity sort of blood, and really make sure the tissues that are having compromised blood flow get as much oxygen as they possibly can. So we'll generally put on like a non-rebreather face mask at about sort of 10 liters. You can also, of course, use nasal cannula, of course, but it's a good idea to make sure that your child's oxygen saturation stays above 95%. Next slide. So IV access, so important and so difficult at the same time. So sepsis management requires immediate IV access. It requires IV access for multiple things that you can see here on the left-hand side of the slide. You can, draw your bloods at the same time as you get IV access, but most importantly, it's needed for fluid resuscitation, antibiotics, and in select cases, vasoactive medications. So I can't even tell you the amount of times where we have a patient in the emergency room, somebody says they are concerned for sepsis, we order an IV and blood work right away, and an hour later, I find out, or the team finds out, that the poor bedside nurse, has been trying for an hour to get IV access on this patient, and they just can't. because for multiple reasons, either the child is sort of has lots of subcutaneous tissue, or the child is significantly dehydrated, or they just have difficult veins, or, you know, for a multitude of reasons. So the first thing I would say to you is just recognize that this is sort of an emergency situation, but it should not fall all on one person to solve this issue. But again, when it comes to sort of raising your voice, I say that because just recognize that this is an emergency situation where IV access really should be established within, we say, about 10 minutes. So if you can't get IV access in 10 minutes, and that happens all the time, you want to make sure that you escalate that to somebody else, whether that is your charge nurse, or in select cases, there are IV intravascular teams, or there are people who have skills like ultrasound capabilities to sort of look for ultrasounds and look for IVs in different ways. Whatever that may be, the point is, don't let this just go on sort of for 30 minutes, 60 minutes, 90 minutes, sort of 2 hours. IV escalation pathways are very, very helpful in these scenarios. Not all hospitals have them, but you'd be surprised, many do. So it's a good thing to sort of look into. At Sick Kids, we have a clear policy in terms of sort of under urgent circumstances, which this would be considered one, how many times an initial RN is supposed to try before you escalate to somebody else. We use intraosseous access all the time in the emergency department. I recognize that it's not used as frequently on the floors, of course, but is an incredible option, and is in the emergency department certainly our go-to after we have tried establishing IV access peripherally, and we can't. Next slide, please. So we talked about putting in this IV and ideally drawing off some blood work. I do want to emphasize that if you, for whatever reason, can't get blood work, the IV access is your priority because it's what you will need to deliver fluids and antibiotics. So if for whatever reason you can't get blood work, that's okay. I would sort of prioritize the other things. If you can get blood work, what are you looking for? So on the left-hand side, the top part sort of suggests, again, that the complete blood count, looking for signs of infection on the white blood cell count, and of course, blood cultures. Ideally, blood and, if applicable, urine cultures should be obtained prior to starting antibiotics, so you can see your culture results and determine whether there's an organism in the blood that you should be directing your treatment at. Other investigations, depending on the scenarios, to elucidate the site of infection would include chest x-rays if you suggest a pneumonia, abdominal x-rays in select cases, and then other wound and viral studies as needed. On the right, you can see the other blood work that we generally recommend if you are concerned that a patient may have sepsis with organ dysfunction. So again, like we talked about, when organs and organ systems don't get the blood flow and perfusion they need, their function is compromised. So what does that look like from a cardiovascular dysfunction standpoint? I sort of talked about how you can detect that clinically a lot of the time. So if a patient is not mentating well, if their skin is cool and clammy, they're obviously not getting the blood flow that they need to their peripheries. And that's a sign of cardiovascular dysfunction. But on blood work, you can also sort of pick that up in select cases where maybe the clinical picture is a little confusing or maybe not that clear. If you see a low pH or an acidosis on your blood gas, or you see a high lactate on your blood gas, that is also a very good sign that your body is not getting the perfusion or the oxygen that it needs. So lactate, for those of you who are interested, is generated by something called anaerobic metabolism. So when your body doesn't have the oxygen it needs to generate energy, it switches over to this other way of generating energy, and the byproduct is lactate. So lactate, again, suggests that your tissues are not getting the oxygen that they need. When your kidneys don't get perfused properly, your urine output falls and your creatinine can go up. So a rise in creatinine is a indicator that kidneys are not being perfused properly. Hepatic dysfunction is often detected by elevated transaminases and elevated bilirubin. Hematologic dysfunction can be picked up by a decrease in platelets or an increase in coagulation studies, such as the INR. And again, respiratory compromise can typically be detected not only by physical exam, where a child is clearly having trouble breathing and may need oxygen, but by a respiratory acidosis on their blood gas. Electrolyte abnormalities are very common in sepsis, very common. Probably the top ones that you should be aware of are glucose abnormalities, specifically low glucose, and many of these kids need to be bolused with glucose. I'm happy to talk about that further if anyone has any specific questions. Calcium abnormalities, and then due to like fluid shifts and dehydration, sodium abnormalities are common as well. So you want to make sure you pay attention to all of these. Next slide, please. So after you've established your IV access and you're ready to deliver some fluid, what can you give? So first line options sort of vary a little bit, but generally it's always a crystalloid solution. So what that means for the most part is either normal saline, which is usually our fluid bolus of choice at sick kids, or LR, which is lactated ringers. There is actually studies, there are lots of studies actually going on right now to sort of figure out which of these two is better. There's some evidence already actually that LR might actually be better and safer than normal saline. But bottom line is that whatever you have available the quickest is completely okay. I'm so sorry, Michelle, I just seeing a comments now. What are the abnormal lab values for peds patients? This is great. So like everything else in pediatrics, even the creatinine ranges differ depending on age ranges. So generally speaking, I'd have to look this up to tell you with 100% certainty, but the criteria generally define a certain increase from the normal per age group. So for example, if your creatinine is twice the normal level for a 3-year-old, that's, considered elevated, let's say. But again, all these ranges differ depending on the age range of the child. I did put, if you refer to the slides again, the paper that all of these organ dysfunction definitions actually are from is at the bottom of that slide. So if you are interested, they clearly sort of defined what the definition of each of those organ system dysfunctions are. So going back to fluid resuscitation, so as I mentioned, lactated ringers or normal saline are both perfectly appropriate. The latest 2020 Surviving Sepsis pediatric guidelines suggest that a bolus of anywhere from 10 to 20 milliliters per kilogram is acceptable. The most important point I want to drive home here is that generally speaking, so these boluses need to be, especially if you have a child who you suspect is having septic shock, so again, signs of impaired perfusion, these boluses should be administered rapidly. And by rapidly, I mean over about 10 minutes. So at Sick Kids, we've really sort of been trying to move away from the IV pump for a couple of reasons. The IV pump, as most of you know way better than me, because they're used to using it way more than I am, the highest rate you can infuse something on the IV pump, right, is 999 per hour. So a liter per hour, right? So if you, for example, have a 30-kilogram child, you want to give that 30-kilogram child 20 cc's per kilo. So that's 600 cc's you want to deliver. Even if you put that on the pump at 999 per hour, it's going to take about 35 minutes for that fluid bolus to go in. The other, I would say, pitfall with using the pump is that we all do the same thing. We hang something on the pump and we walk away. And we maybe come back like an hour later when we have the chance after we've sort of done a few other things, because we know that, it's on autopilot. It's going to go in. It's set on the pump. But the idea here is that the fluid should go in very quickly, and the child should be reassessed immediately after that fluid bolus goes in. So really none of this sort of walking away and coming back. It's sort of stay at the bedside for that delivery of fluids and see how the patient is after the fluids have gone in and see if they need more. So many children may need 2 to 3 fluid boluses. So that's up to 60 cc's per kilo. Sometimes kids will develop signs of fluid overload before that, and actually you should stop the fluid delivery before you reach that 60 cc's per kilo. And we'll talk a little bit about that. Oh, great. So you definitely can use gravity, but even gravity in itself won't be enough to deliver this amount of fluid in this time frame. Typically in pediatrics, you're using anywhere from 24 to 22 gauge IVs. If you're real lucky, like on a, an older, really a teenager, maybe you'll get in a 20, but the large majority of our patients probably have 24 or 22 gauge IVs. So even if you just sort of open something up to gravity, it won't go in as fast as you need it to. Now, pressure bagging is definitely another approach that if you're in a pinch, you can do as well. The only problem is, again, a 24 gauge IV is not going to deal well with sort of fluids under that, necessarily under that degree of pressure being pushed in. So I'll show you in the next couple slides another sort of couple quick suggestions about how this can be done. So next slide. I did just want to quickly mention this idea of sort of fluid overload and what to look out for after you give a patient a bolus. So you do want to make sure that you look out for some worsening respiratory status, which could signify buildup of fluids in the lungs. You want to feel for new or expanding hepatomegaly, and you want to listen for crackles in the lungs, which, of course, may be hard to detect, especially in sort of a hectic resuscitation type of scenario. But if you detect any of these signs, you want to at least entertain the possibility that the child is becoming fluid overloaded. Of course, this can be a little tricky because children can naturally, through the progression of sepsis, get worse without it necessarily be attributed to fluid overload, but something you want to look out for. Next slide. So the really easiest way to get fluid in, which is the least fancy way in the world, is just by syringing it in. So at Sick Kids, what we'll do is we'll draw up 60 cc syringes full of fluids, and we'll have someone, if a child is looking very unwell, we'll have someone literally push in manually 60 cc syringes full of normal saline directly into a child's IV. On the right-hand side is what we call like a push-pull technique using a three-way stopcock. Slightly fancier, but definitely not super fancy. It can be done absolutely anywhere. The idea here is that, hopefully this sort of displays fairly obviously in the photo, but you actually have a system that's hooked up one way to the patient, one way to a bag of saline, and the other way to, let's say, either a 20 cc or 60 cc syringe. And what you do is, like, initially you shut the three-way stopcock off to the patient, and you pull fluid out of the saline bag into your syringe, and then you switch the three-way stopcock so that it's off to the saline bag, and you then push that fluid that's in your syringe directly into the patient. It's just sort of a quick way to avoid having to continuously refill the syringe a different way. So this just helps you sort of refill your syringe quickly. Hopefully that sort of makes sense to everyone, and feel free to put some questions in if it doesn't. Do you do 1 times orders for each fluid or sign off? This is a great question. So do you mean as opposed to, let's say, ordering 3 fluid boluses at once? Is that what you mean, Michelle? Like ordering them one at a time? If that's what you mean, that is a great question, and was sort of supposed to sort of come up as a point later. But yes, that is the best way to do it. And the reason that's the best way to do it is because I can't really overemphasize the importance of reassessing after each bolus. So if you start, sort of just ordering up 3 boluses, first of all, your patient may get better after 1 bolus and not even need any more boluses, or they may develop pulmonary edema after bolus number 1, or they may need more. So it could be any of these possibilities. So you really want to make sure you order your boluses 1 by 1, and that you have both nursing and provider at the bedside to sort of assess how the patient responds. Next slide. Antibiotics. So the take-home point from this slide is that don't get too fussed sort of about the timing, but the antibiotics should be administered as soon as possible if you suspect sepsis or septic shock. Now, if a patient is in florid septic shock, meaning, again, they have infection, the systemic inflammatory response, and signs of impaired perfusion, the gold standard is within an hour. Otherwise, most of us would support that it's reasonable to get antibiotics in within 3 hours, but I think your overall goal should be really as quickly as possible. Next slide. terms of, I think we listed sort of antibiotic choices. Again, these are just sort of what we recommend for the large majority of children at Sick Kids right now. But again, these may differ depending on your organization and your local organisms and susceptibilities. I think this is a generally accepted, very reasonable starting point for empiric antibiotic coverage when you don't know the causative organism. So for most kids who are 1 month and over, the appropriate regimen is ceftriaxone and vancomycin for these kids. Now, if you're concerned about other types of infections, there may be other antibiotics that you would add. And generally speaking, for neonates, we recommend something slightly different. But these, I think ceftriaxone and vancomycin is an excellent place to start, which should give you coverage for most things. So the one thing I will add is that if you do have a strong suspicion that the source of infection is coming from the gastrointestinal tract or somewhere where there's a significant amount of anaerobic organisms, you do need some extra coverage. And that's when you want to continue consider adding on something like a Flagyl or metronidazole, or giving coverage with a broader spectrum antibiotic like piperacillin and tazobactam, which covers for all those anaerobic organisms. But this could be a whole separate talk in itself. Next slide. So we'll go back to, in the interest of time, we're just going to sort of, I think maybe let me know, Alicia, if we're sort of strict on time, maybe we can skip over this. What do you think? Let's just skip over this. I think it's reasonable to just sort of finish off the material. So we talked a little bit about fluid resuscitation and then giving up to 40 to 60 cc's or milliliters per kilogram as needed or as tolerated by the patient. So what happens after you've sort of reached that point and you've given 60 cc's per kilo and your patient is still markedly tachycardic, looks unwell, they're cool and clammy? This is the time where we consider vasoactive medications. You may typically not be using these very often on the wards. If you work in an emergency department, we do use them all the time. And certainly sort of a take-home message would be times have changed from clearly from like a decade ago, where you can and should start these medications via peripheral IV as long as you have the safe resources and support and guidance to do so. So either epinephrine or norepinephrine are now supported as first-line agents. To be honest, I would probably use whatever your institution is most comfortable with and has the most experience with, but either of these are acceptable. There are sort of subtle differences between when you might consider one over the other. We used to use the terms cold shock and warm shock. We don't use those really anymore because it's been proven that what a patient sort of looks like from the outside doesn't really correlate with sort of necessarily what the physiology is underneath or what is going on exactly with the heart or the blood vessels. But for the purposes of this group, again, either of those are appropriate. If you don't have either of those, there are guidelines for dopamine as well, but typically epinephrine or norepinephrine is the preferred agent in that case. Obviously, you want to be doing this in conjunction with someone with ICU level expertise who can help guide sort of dosing and management. And any child who is going to need vasoactive medications is going to need ICU level care. Next slide. So you've sort of done all of these things. You've given fluids, you've covered with antibiotics, and maybe even started vasoactive medications. How do you know when you've done enough or when you've met your goals? So sort of talked a little about, Tiffany mentioned the idea that low blood pressure is a really, really late finding. I'll tell you that if you have a child who's exhibiting signs of sepsis, who's hypotensive, they are so sick at that point. Like mortality rates skyrocket at that point. The large majority of cases that you see of pediatric sepsis will not have low blood pressure. So I don't want you to sort of look out for that because the large majority of cases won't have that. So you can't look for normal blood pressure as your reassuring sign that everything is okay. So what else will you look for? You'll look for a normal capillary refill time, normal pulses, normal pulse pressure, improvement in mental status, an improved urine output, and then sort of one of the most important ones is actually not on here, but an improvement in their heart rate is really, really important. Next slide. So just a word on source control. I just think it's important to sort of remember that while it is important to treat with antibiotics, if you don't get rid of the source of your infection and you have an ongoing source that's in the body, you'll run into trouble. So there are select cases like this. For example, if your central line is the source of your infection and the source of sepsis, you can treat with antibiotics, but unless you take out that line, you'll still run into trouble. Probably the most common one we run into is things like abscesses or necrotizing fasciitis in the emergency department. Again, if that infected tissue or infected pus or nidus of infection is not actually taken care of or removed, you won't be able to solve your problem. So just sort of a word about keeping an eye on that. Next slide. And then, as I sort of mentioned, usually I would say if you're needing sort of more than 2 fluid boluses, you need to be sort of thinking about transfer to a higher level of care, whether that's in your local hospital or in another hospital. So you want to start sort of early planning for transfer, and you want to be prepared for things like ongoing fluid resuscitation, intubation, vasoactive medications, and in select cases, hydrocortisone. And you know, this is usually reserved for really cases that are not responsive to either fluids or vasoactive medications, or in patients with select risk factors. And people in a critical care setting can often help guide management regarding decisions for these meds. Next slide. So some key points to remember, again, as was mentioned at the very beginning, sepsis can occur in any child, but you want to pay close attention to children with high risk indicators that we talked about. You should remember that time counts in these situations. That first hour and what you do in those first 60 minutes in terms of recognition, delivery of antibiotics, delivery of fluids of its utmost importance. Low threshold to escalate. Don't worry if you're not 100% right about a patient having sepsis or not. If they're a patient who has signs of infection, has a high heart rate, and is exhibiting other signs of impaired perfusion that we talked about, you should absolutely consider sepsis at the top of your differential and share that thought with those around you. Next slide. And then, I think I just put this in as a reminder, just that, Alicia, hopefully maybe we can share these. The Kids has a video series of basically sepsis recognition and management that I think we'd be happy to share. They go into a little bit more detail even than we did today on sort of everything that we talked about. And that, I think, is all I was going to share. I see a comment from Michelle, who I just haven't had a chance to read. Do you have sepsis bundles built into your order sets? Also, not sure if there's Q-SOFA scores. Okay, that's great. So we don't, if we have sort of a version of bundles, kind of a complicated question. We have order sets. And we have everything that would be needed in that first hour of resuscitation in the order sets. So we have order sets that includes all the blood work, sort of with one click that you would sort of want to evaluate for organ dysfunction that I talked about in an earlier slide. We have clicks for the antibiotics that you would need, and then separate sort of clicks for the boluses, like bolus 1, 2, 3, 4 that you would need in these scenarios. We don't have sort of bundles per se, because there's no sort of widely accepted bundles in pediatrics per se. However, I will say I consider sort of initial fluid bolus, antibiotic administration, and blood work a bundle that should be done within that first hour. And then a great question about Q-SOFA scores. So Q-SOFA scores have not been fully validated in pediatrics. There's definitely, there's SOFA scores and Q-SOFA scores. So the SOFA score itself, there's a version of the SOFA score that's called the P-SOFA score, which is the pediatric SOFA score. And that score shows some promise. It's basically a SOFA score that is an adaptation to the pediatric population. So like we talked about, all the basic measurements of things like creatinine and all those things are for adults in the SOFA score. So the P-SOFA score is basically adapted for pediatrics. And it's undergoing study right now, but has not been fully validated in the pediatrics population. The Q-SOFA score is actually what's called a quick SOFA score, which is only based on 3 elements, which is supposed to be used really sort of in the emergency department, ideally, as like a really quick, I can't even remember offhand, respiratory rate is one of them, but there's only 3 elements in the Q-SOFA, which basically sort of, should I be concerned right now about sepsis? And actually hasn't been validated at all in pediatrics. So unfortunately, like the Q-SOFA, we can't really use it all. I do suspect, so the definitions for sepsis right now as we speak are undergoing revision. And I do strongly suspect that a version of like the P-SOFA will play a role in some form or another in the future definitions of sepsis. So stay tuned for that, because we're using now sort of definitions from 20 plus years ago. So I think things will change a little bit. I think the general thoughts around, clinically recognition of sepsis are not really going to change too much, because clinical recognition and recognizing signs of impaired perfusion will stay the same, but laboratory elements may change. Hopefully that's helpful. Bit of a long-winded answer, but so hopefully that was helpful. I think I speak on behalf of all of us when I say feel free to reach out if you have any questions or comments, but it's been great talking to you guys today.
Yes, thank you so much. And thank you, Tiffany and Debbie, both for being here today. Everybody on the call, or if you're rewatching this recording, you can scan the QR code on the screen to provide some feedback in an evaluation form. And then, like Debbie mentioned, our sepsis resources are on our Connected Care Community Resource Hub, so on the website that I've shared with the clinical leaders. And if you are watching the recording, it's on the Connected Care website for community hospitals. The sepsis video series is there, so you can find it there, and you can watch this recording as well. So thank you very much, everybody, for joining. If you have any questions, we'll stay on, but otherwise, thank you so much.